Hello and welcome to the wound presentation, Wound and the Nursing Process for Unit 5. This presentation will take you through applying the nursing process to skin integrity and wound care. We start with assessment. The Braden scale is a tool designed to measure the risk of skin breakdown and includes assessing sensory perception, moisture, activity, nutrition, friction, and shear. We want to assess the skin breakdown risk on admission to document any existing lesions and daily for patients at high risk. We assess all areas of skin from head to toe. Check at the baseline. What are the patient's normal skin characteristics, and are there any actual or potential areas of breakdown? What areas are at most risk for breakdown? The heels, sacrum, elbows, and occiput, or back of the head. We want to reassess daily for high-risk patients and document the assessment. If you notice hyperemia, check if it's blanchable or non-blanchable, and then document the location, size, and color. Recheck in an hour. If it's still there, document and check for induration, which indicates progressive tissue damage. If a wound exists, perform a full wound assessment. It's very important to note wounds that are present on admission because even if they were there and nursing doesn't document them, then the hospital gets blamed for a hospital acquired pressure ulcer. So after we assess, we cluster data and form a nursing diagnosis. If your client has a wound, these are potential nursing diagnoses to consider in your care plan. We also want to assess factors that contribute to diagnosis, and these then become the focus of your interventions. After the diagnosis, we begin to plan. We identify potential outcomes for the patient based on their problem. So take a minute and think of some potential nursing interventions for impaired skin integrity. What can nurses do to maintain intact skin? The next step in the nursing process is implementation. This is where nursing interventions are carried out. These should be nursing interventions or collaborative interventions that support wound healing. So for example, you could provide nutrition, adequate protein, vitamin C, A, B1, B5, zinc. Fluids, you want at least 2,500 mils a day if not contraindicated. Promote good rest, prevent infection, provide systemic support, oxygen, blood sugar control, and then consider medications the patient may be on. For example, prednisone delays healing. Topical skincare interventions include daily assessment, pay attention to bony prominences, and do not massage red areas because this causes more injury. Use a mild cleansing agent. If there's dryness or cracking, use a good moisturizer. Examine edema and moisture, and then you can also put on prophylactic foam dressings to high-risk areas such as the sacrum or heels. And then if your patient's incontinent, you want to use a moisture barrier to protect. This zinc oxide barrier paste works pretty good, especially if the skin's already irritated. Treat incontinence. Consider a fecal incontinence collector if they have diarrhea. And if you use pads or chucks, you want to select those that wick moisture away from the skin and don't leave them on for long periods of time. This slide shows several nursing interventions from your textbook. Key highlights include repositioning at least every 2 hours, keeping the head of bed below 30 degrees, and to keep the heels off the bed, usually by putting them up on pillows. So sometimes dressings must be applied to wounds, and you want to be sure to select the proper dressing for the type of wound and for proper healing. So this is going to depend on the patient and what's going on with them. Some dressings are listed here. Gauze is the most common. You can use it to clean and pack or to prevent moisture to the wound bed, but allow drainage to wick up out of it. Just know that you could get maceration or waterlogging with the gauze because it just sits there wet. Transparent Tegaderm dressings are often used to secure other dressings or for like IV insertions. They let oxygen in, but they don't let water and bacteria in, and what happens a lot of times is moisture just kind of builds up underneath of the dressing sometimes. Hydrocolloids like Duoderm or Tegaderm are for pressure wounds with light drainage but not infected. They can be left on for several days, and they provide a moist environment without the maceration risks, although they can be a little hard on the skin when you take them off, so they're not used too much anymore. And then hydrogels promote moisture. Polyurethane foams like Liofoam or Aleven, they absorb exudate, but they have to be taped or sealed. They don't have any adhesive built in. And then alginates like seaweed are put on, and they absorb up to 20 times their weight, and they require a second dressing over the top also. But when they get saturated with the patient's drainage, then they turn into a gel, and they come off pretty easy. This slide shows some examples of when certain dressings can be used. Like I mentioned before, duoderms are not as commonly used anymore due to advances in dressing types and just ones that aren't quite as harsh on the skin when they're taken off. So there's lots of options to secure dressings, and what you need to take into consideration is how often the dressing needs to be changed. Paper tape is less irritating than regular tape, although you still can get some pretty nasty tape burns or pulling away of the skin with paper tape. So it's important to apply a skin barrier around the wound that makes like an extra kind of skin layer almost that gets pulled off instead of the skin. Montgomery straps are shown here in this picture, and these are really good if you have somebody that's got a abdominal dressing or some kind of dressing that's a little bigger on a bigger area of the body that needs changed frequently, because you can those white rectangle pieces stay on, and you just take the dressing out of the middle, so you're not ever having to apply and take off and apply tape to their skin. Binders can go over the top for more protection, and abdominal binders don't stick at all. They're just Velcro to themselves. And then remember pain management. You might need to give your patient analgesics 30 to 60 minutes before a dressing change if it's going to be a painful one. Cleaning of wounds depend on agency protocol and provider order, but usually wounds are cleansed with sterile saline unless it's something else is ordered. So there's lots of different drainage management systems. A wound vac works to increase circulation and perfusion at the wound bed. It reduces excess moisture in the wound by sucking it out of there. It decreases the bioburden, or the number of microorganisms in the wound, because that drainage doesn't sit there, and it decreases then their toxins to the wound bed. It increases cell proliferation, which speeds up healing times by bringing more blood flow to the wound. It's used on open wounds, and the top picture then is an example of a Penrose drain. In a Penrose drain, drainage passively flows out of the drain, which is inserted into an incision or a deep wound. And then the bottom picture shows Hemovac drains, which are the white circle one, and then JP drains, which are the clear bulb drains. These are compressed for vacuum pressure drainage to provide a constant pressure sucking the drainage out. There are a couple kinds of debridement, and debridement is the removal of foreign material or dead tissue from the wound, and this is done to encourage or promote wound healing and discourage microorganism growth. Surgical debridement uses sharp instruments to debride the wound, and this is done by a qualified health provider such as a surgeon or a wound care nurse. We would never be responsible for this unless we were specially trained. There's enzymatic debridement, which is using chemicals in the wound bed to help break down necrotic debris. And examples of this are collagenase or Silvadene. Autolytic debridement is removing debris and necrotic tissue using the body's own fluids and cells, and to do this, an occlusive dressing or a hydrogel is applied over a wound, allowing wound exudates to build up, and often they soften non-viable tissue, and then it makes it easier to be removed by surgical debridement or rinsing off with irrigation during dressing changes. And then finally, mechanical debridement is removing necrotic tissue using mechanical force, such as wet to dry dressings. Wound debris gets trapped in the dressing as it dries with the wet to dry, and then it's pulled out with the dressing changes. So It works, but it's very painful and it's non-selective, which means it can move the good tissue or remove the good tissue as well as the bad tissue. Traditional wet to dry dressings are used to pack an open wound. If they're used for pressure ulcers, they're for mechanical debridement only, which remember means it dries on there and then it pulls out whatever tissue is connected to it. But the problem with these dressings is that it causes maceration of surrounding skin. It removes good granulation tissue. The excess of moisture in a wet to dry promotes bacterial growth. And so you may advocate for your patient and request a better dressing selection, especially with all the advances in dressings. There are so many different types of dressings out there that might work a little better. Sometimes, though, you don't have a choice if it's a packing type of a dressing. This table discusses heat and cold application and their indications, so you can take a minute and read through that. I won't read it to you. And then this one is a little bit more information about the safe use of heat and cold, so just take a few minutes and read this too. Pay attention to how long you can keep heat and cold on. Heat especially will work good for a while, like I think it's 15 minutes or so, and then after that it actually gets kind of negative effects. So after we complete our nursing interventions, it's time to evaluate the care plan. What are we hoping to see? How do we determine if the nursing care is effective? Well, we should see improvement in pressure ulcers within 1 to 2 weeks, depending on their severity. Improvement includes resolution of peri-wound redness in a week, 50% reduction in wound dimensions in 2 weeks, maybe a reduction in the volume of exudate, decreased pain intensity during dressing changes. And then if there's no improvement, just reevaluate the factors contributing to the impaired healing, reevaluate the dressing selection, and also evaluate the patient and family's need for education and support services, and initiate referral processes if necessary. And this concludes our presentation on the nursing process and related to wound care. So thank you for watching and have a good week.